All right, good morning, everyone. Thank you so much for joining us for our routine joint media availabilities. We have with us today Dr. David Peterman. He is the CEO of Primary Health. We also have Dr. Joshua Kern. He is the Vice President of Medical Affairs for St. Luke's, particularly in the Magic Valley area. We also have Dr. Jim Souza, the Chief Medical Officer for St. Luke's, and then we are joined by Dr. Stephen Nemerson, the Chief Clinical Officer for St. Alphonsus. They are going to answer all of your questions, but first we have just some short presentations and some data that we can share with you. If you go ahead and mute and turn off your cameras at this time, once we get to the questioning, you're welcome to turn those back on and ask your questions yourself, but we'll right now allow the physicians to speak with you and get things started with Dr. Peterman. Good morning.
Do you want me to go ahead, Anita?
Yes, please.
Okay. Well, thank you, Anita. I'm going to correct one thing Anita said, which is she used the words routine. The point of today's talking with you is there's nothing routine about what we're mentioning, and I know Anita agrees with that statement. I have some slides, and Anita, you can go ahead and pull them up, but I had a couple of comments to make before we get started. This group of physicians that I've been working with, you might want to get back to the top of the slides there. I think there's an introductory slide. Yeah, there we go. So what I wanted to say was I've worked here in Idaho since 1980. And I will tell you that never in the history of my being here in Idaho have I had a working relationship with the physician leaders of the community like we all have had this last 3 to 4 months. And I will tell you that in our normal day before COVID, all of us are focused on our own organizations. And we certainly do communicate with each other, but our primary goal is to work with our own organizations to serve the community. And certainly there are times that these different organizations actually compete. But the point I want to make today is never have I worked so collaboratively with this group of physicians. And that should tell you how critical, how important, and how we're really at a crossroads here. I would also tell you I have enough gray hair to say these are some of the smartest doctors. I've worked closely with a lot of doctors. These are very, very good doctors, and they are the leaders in their particular hospitals and organizations. And I want to have an impact today, so I'm urging you to help us to have an impact on the community and what we're trying to say today. The second thing I wanted to mention was that certainly the issue of mask mandates or other mandates are going to come up. And if you would talk to this group of physicians, of course, when it's appropriate, we support mask mandates. But there might be a variation among us. That is, someone might say we should start it earlier, someone might say start it later, someone might say it should be the whole state, someone might say it's the county. And my point is, that's irrelevant. For us to waste our time arguing over whether or not we have a mask mandate is missing the point. These doctors are going to tell you today, wear your mask. That is the way we protect each other and protect our community. So I wanted to just get that out there. Yes, we can answer questions about mandates, but that's not the point. The point is, you have to wear your mask. I have to wear it. You have to wear it. And of course, we have to distance and wash our hands. So that's the opening lecture. I'm trying to figure out what's the best way to have an impact. And today, I want to urge you, I have a little presentation, but listen to these doctors. They are the best. And we're going to tell you how critical it is here in our community and what we need to do. So I think that's the end of the lecture, I guess, my part of the lecture. And let's go ahead with my first set of slides. Yeah, I think we're ahead. Yeah, there's the first one. So this information isn't, Okay, there's the introduction. This information, it's not so much that this is different information, but it's different in the sense it's in the New York Times. And this slide shows you their graphic evidence of Idaho, which is on this date, which was October 26, based on their measures, has 350 cases per 100,000. And so if you look at that color graph at the right, and you look at way over to the right, which is October, we're in the red. And we're 1, 2, 3, 4, 5, 6. We're 6 in the country. This is not where we want to be, number 1, or in the top 10. Next slide. Okay, this is from the White House COVID Task Force report. This actually is not officially released. I believe there's an organization that gets this through the Freedom of Information Act and publishes it. And again, I'm not sure that you've seen this kind of information demonstrated in this way. If we would go to the graph, the first graph on the left, and that looks at cases per 100,000, according to the White House Task Force, we're number 7. Again, extremely scary, extremely critical, and very worrisome. If you look at the next graph, which is the ranking of the positivity of tests for the last week, we're number 2 in the country. Yeah, you can put the pointer on that red area in the center that says us at number 2. That's frightening. There's no other way to explain that. Fortunately, you go to the last graph, which looks at deaths per 100,000, and I believe Idaho is down there at 38th, which is good. We want to be lower. Again, I think this is just a different way of saying how critical it is, how this surge essentially, in my mind, is on fire, and we're going to hear more from the doctors about it's impacting the hospitals and the community. Next slide. Again, this is from the White House Task Force, and don't look at I don't think they realize that Nampa and Caldwell is our metro areas. But if you look to the right on the top red, it has the counties that are in Idaho that are in the red. And of course, Ada, Canyon, and Twin are in those red districts. Next slide. This is information from primary health. I've shown it before. I'll just kind of review it again. If you look at the total number of tests and you're looking at those boxes at the front, the green is negative, the red is positive, and then you even look at the asymptomatics. The first point to make is we have tested over 50,000 individuals here in Southwest Idaho. What that tells you, there's enough data there that it's very accurate data. Now, I want you to shift over to the box that's on the left side, then look down on near the bottom and you look at October 22nd, October 23rd, October 24th, and you can see the positivity rate, 14%, 12.6%, 14.4, 13.5. You can also see the number of positives, which is, if you go to the top of that box, it's 27, 27, but you see what's happening now, it's 71, 59, 50. So we have the positivity rate increasing, and we have the actual number of patients that are positive for COVID increasing. Next slide. Again, I've shown this before. This looks at the positivity rate, and again, you see in July, after we had the openings related to the bars, and our positivity rates went as high as 14%. Again, we're back there again. If you look way to the right, and you can see that the positivity has gone back up. I haven't separated these out in terms of Ada and Canyon County, and the reason I haven't is they're the same. They're both showing high positivity rates. Next slide. Again, I've shown this slide before. This looks at the absolute number of positives per day. Look all the way back at April when we were frightened by that. Look back in April when Dr. Souza told us about what was going on at Magic Valley. Look how little that is. Then we moved towards July, which was after the opening, and we looked at those numbers and we said, oh my God, we need to do something. Now look way to the right over the left. We are actually, the point there is higher than the highest point in July. We're headed into, I don't know how else to say it, a very scary, a very critical, very worrisome period where so many of the people who live in Ada and Canyon County and Twin Falls area are positive for coronavirus. Next slide. This is a slide that basically shows you children that are being tested in our clinics. And this looks at the positivity rate. The blue is the 5 to 12-year-olds, and the orange is the 12 to 18-year-olds. Now, there is national data that says it seems like the younger children in elementary school are, in a sense, less likely to be positive, and possibly, we don't know for sure, but less likely to infect others. Our data is consistent with that. That is, there are less positives in our elementary school kids. Now, it may be they're more asymptomatic, so in a sense, we're not testing as many, but nevertheless, this data is consistent with national data. Now, if you swing all the way to the right, you look at the blue, you can see it's starting to jump up. Wait, back to the other slide. There we go. If you look way to the right on the blue, the positivity rate for that younger group jumped up to 6.8. Now, I hope that isn't a trend, but it's a concern. Now, if you look at the orange, we see this group of teenagers. They have consistently been higher. They're at that positivity rate 11, 12, which is a concerning positivity rate. That is also consistent with national trends, which at times has described these teenagers as super spreaders. So again, it just gives you a sense of the schools. Now, next slide. And this is, while the absolute numbers are a little bit lower, but you see what's happening here. You look at the teenagers, the absolute numbers, it's heading up there. Every week we're getting more positives. Same with the younger kids. Again, this is just a reflection of the community spread. And before I shift to the next doctors, or I stop, I just want to mention that there is many, all over the country, there's talk, should we close schools? Should we open schools? And I would say that there is data right now that doesn't clearly tell us whether or not schools are necessarily spreading it. I think what the data says is schools certainly reflect the community. And the point I would say that follows that is I believe all the doctors here will agree that if you are going to have a combination of distance and in classroom, you've got to take all the steps. They have to be distanced. They have to wear masks. And most importantly, when you have a positive case in a school, you have to have contact tracing and follow up. Again, I think it's wrong to have arguments over the schools. It's more important that we focus on what we need to do, which is wear masks, distance, and wash our hands. So thank you, and I'll be happy to answer questions at the end, and I want to turn it over to the other physicians.
Dr. Kern, go ahead. You can speak to the Magic Valley specific situation, which has been in the national news a lot this week.
Yeah, appreciate it. And thanks, Dr. Peterman, for the positive comments. I don't know if I would consider myself any kind of expert. I just happen to be the one that's chosen to report the numbers a lot of the times for the Magic Valley community. I only have one slide to share, Anita, that you can put that up. So yeah, again, I'm Dr. Joshua Kern, Vice President of Medical Affairs for Magic Valley, Jerome, and Wood River, and I'm here just to give another highlight of the numbers we're seeing at Magic Valley. This slide here, which is the only one that I have, I think just really illustrates well what we're seeing. This is Magic Valley's hospitalization numbers. And again, you go back to April when Blaine County got hit hard and we transferred a lot of patients from Blaine County down to Magic Valley and had some cases in Magic Valley compared to what we're experiencing, just the relentless march of numbers on the right side from the end of September to current day. The other thing I'll highlight, so the blue is the COVID positives in the hospital, the gray is the total patients in the hospital. I think you can't ignore the total patients in the hospital, which you can see is clearly a lot higher than what we've experienced over the previous 7 months. Pretty significant numbers there. And yeah, if you just pause there, Anita. So to give a little bit of context, on September 28th, which is the Monday right before October starts, we had 16 patients in the hospital. So that gives you a sense of what the scale is on that blue bars on the right side. And then it's just been a steady march, October 5th, 25, October 12th, 35, October 19th, 41, October 26th, 55. I think that really illustrates how significantly the numbers have climbed through the month of October, and in particular the last sort of 2 weeks. A little bit of context for cases in the community for Magic Valley. We have had in Twin Falls, 38% of all of our COVID patients ever have been diagnosed in the last 3 weeks. So again, it gives a little bit of perspective of how significant the numbers we're seeing in Magic Valley is. We were again on a diversion overnight because the hospitalist service was too full. It seems to be shift by shift on how many patients we have. Our COVID unit is 97% full. Our medical floor is 92% full today. So again, we're right there on the brink of needing to start to transfer patients back up to Boise, and staffing remains the main issue. We are trying to recruit some travelers to bring them in from outside, but many communities, particularly here in the Mountain West, are experiencing these surging numbers of COVID patients, and so it's not clear we'll be able to get that staffing. And when you have as much community spread as we're having, there's some data out of University of Idaho that as many as 1 in 24 people in Twin Falls right now has coronavirus currently. You inevitably get a lot of staff out sick, and so we're experiencing that issue as many other businesses in the area are. And I highlighted this in the governor's address yesterday, but we have businesses that have their doors locked right now in Twin Falls because too many of their employees are out sick with COVID. And I continue to say that controlling the virus is really the only way to keep the economy going. I think we've created this false narrative that there's two choices: let the virus run its course and keep the economy open, or control the virus and shut down the economy. And I continue to feel that is it's a false dichotomy between those two ends of the spectrum, and really controlling the virus is the only way to keep businesses open, and frankly the hospital staff and critical services like fire and police staff. If people are if our firefighters or our police are out sick, there's not going to be anyone to fill that gap for us. So I will pause there. Anita, I see there's a question for me here. Do you want me to
We'll come back to those
for that, or? Okay.
Yeah, we'll go ahead and come back to those. Let's go to Dr. Souza and then Dr. Nimerson, and then we'll start getting to the questions all at one time for all of you. Go ahead, Dr. Souza.
Great, thanks Anita, thanks Josh, and thanks to my colleagues. Agree with Dr. Peterman, the collaboration's been wonderful. We're experiencing these gigantic increases in disease activity across all of southern Idaho now, and our hospital capacity is eroding rapidly. I've said before, and I'm going to say it again today here, that the rate of expansion from this infection can turn on a dime, and once again we're seeing that. Anita, if you could call up the testing slide, please. You know, we serve a number of counties across southern Idaho, and you're all aware of the increasing activity there. Jerome County, for example, is up to 55 cases per day per 100,000. Twin Falls County is up to a whopping 86. Canyon and Ada County, which were down in the 10 to 15 range, cases per day per 100,000 for many weeks, are now up above 30. And we're nowhere near herd immunity. We're so far from that, and I think Blaine County tells that story. I think the folks on the call are probably aware that Blaine County had one of the highest rates of COVID-19 in the nation in March and April of this year, but they also remain vulnerable. And the proof in that is their current cases per day per 100,000 being up around 30 again. This is our test positivity rate, and similar to what Primary Health Medical Group shared with Dr. Peterman, we're running at about 14%. It's also important to note that these less populated, more rural counties, which often lack the capability to take care of a critically ill COVID patient, they're counting on our urban centers in Twin Falls and Boise and Meridian and Nampa to provide that care. So the point is that we're all connected, and essentially our larger facilities are the neck of the funnel. Within our hospitals, capacity for care is eroding and the funnel is getting clogged. Anita, if you'd show, yeah, our hospitalizations. Only 3 weeks ago, our daily census at St. Luke's of COVID patients across our health system was in the 30s. 1 week ago, it was up in the 75 range, and yesterday and today we're hovering at 90. We have 12 to 15 patients in ICU locations at this time, and we know this is going to increase since the timeline, of course, is exposures, then cases, then hospitalizations, then ICU hospitalizations, and then deaths. So as the community cases have surged, we can see what's coming. Overall, our intensive care units are running at 125 to 130% of their usual volume. And recall, please, that COVID patients are only one part of this story. We are, for example, seeing a 25 to 30% increase year over year in stroke and heart attacks, some of which is probably related to COVID, given the well-known association between that disease now and the formation of clots. Of course, it's not just a matter of beds. Just as important as the beds is having healthy people to take care of the people in the beds. Today, right now today, we have 108 people out sick with confirmed COVID. Almost 70 of those are clinical staff. And the overwhelming majority of these cases are being acquired in the communities where these folks live. They've acquired them in businesses without safe practices, or at public gatherings or multifamily events in backyards. I want to share that we're not just standing by and waiting. We've been in constant preparedness and get ready mode since March. We've hired more than 500 nurses since March. We're actively seeking traveler nurses. We've been preparing our inpatient facilities for a surge. Last week, we came very close to activating the next phase of our inpatient ICU capacity plan, which would mean closing down our cardiac observation unit and turning it into an intensive care unit. This, of course, would mean that cardiac and vascular surgical patients who need procedures, but they're less time sensitive, would need to wait. We came so close that we actually assembled the equipment to make this happen. We did just eke by and we're able to hold off on that for now, but with the numbers that we're seeing in the community and knowing that sequence of events from exposures to cases to hospitalizations to ICU hospitalizations, we believe it's now just a matter of time. We can turn our hospitals progressively into COVID units. We're prepared to do that, but that comes with a heavy price in terms of access to care that we all need. Finally, I wanted to say something about our people. Our people, our healthcare providers are amazing, and they're getting fatigued. They're fatigued of the physical burden of care and the extra shifts. These critically ill patients are very sick. They often cannot move. We have to move them. We have to attend to every physical need. So the physical burden is high. The psychological burden is high. Needing to limit visitation in the name of safety and containment. This hasn't been our standard operating procedure. Our nurses and providers are compassionate people, and it's difficult. They're also fatigued of watching a disease process play out that we know is highly preventable. We're seeing way too much needless suffering and death. Much of this is preventable within our facilities. Just using them as an example, transmission of the virus is rare, despite the fact that we have many hundreds or even thousands of people each day interacting with confirmed COVID positive patients. And the last thing that's causing fatigue is I think they're fatigued of living in two worlds. They live in this world at work where they use good practices, they observe good practices around containment all the time, versus the public square where these behaviors are just too often not on display. So I'm going to turn it to Steve here in just a second, but we're in a closing window of opportunity here to intervene. Action is required now. We appreciate the action the governor took and appreciate his call for individual responsibility. The message here is very simple. I agree with Dr. Kern. We do not need to shut down large segments of our economy, but when you're with other people besides your own family, put a covering on your face and watch your space, period. With that, I'd like to turn this to my colleague, Dr. Stephen Nemerson, who is St. Alphonsus Chief Clinical Officer.
Thanks, Jim. And I want to also reflect the incredible collaboration that we've had as a group of physicians and leaders across the state of Idaho that Dr. Peterman commented on at the beginning of our presentation. There's a reason that we're coming to you as a group of physician leaders without our administrative leader dyads. And the reason for that is we want to make a very strong and powerful statement about the nature of this disease and the ability to turn the train around. I'm going to show you St. Alphonsus' experience, but I will tell you it mirrors what you've heard here. And I hope to offer something a little bit different in terms of perspective, which is what previously has caused the decay in COVID in our communities. So if I could have the second slide, Anita. And so here you see the Central District Health and national numbers in terms of growth in Idaho. And what we're seeing is that steady growth in COVID due to community spread that's been referenced previously. But I want to comment on three things, which is current situation and the previous surges that we experienced. Back in April, we started to have the beginning of exponential growth, and that was shut down promptly by a shelter-in-place order from the governor. Then again, in the beginning of June and progressing through July, we saw an incredible surge, and we saw some degree of decay beginning in August. And the reason for that decay was some local mask mandates and the messaging, strong messaging that you helped us to deliver around individual responsibility for face covering and physical distancing. We also benefited from the fact that the weather was good, and so people were able to engage in activity outside of closed indoor spaces, which is now a problem. And now we're seeing this surge beginning at a higher level. So our foundation in early September was a higher incidence of COVID in the community from which we're growing. And you can see that the incidence and the prevalence of COVID in our communities is much, much higher than it was back in July. Next slide. I don't need to comment on the active cases per 100,000, which others have commented on, except to say that in this graphic, white is considered epidemic control. Anything that is dark pink or red is considered out of control. And you'll notice that the majority of the counties in Idaho are out of control as far as the growth of this epidemic. Next slide. This is St. Alphonsus' individual experience at present, and what you see, as I said, mirrors exactly what St. Luke's and Primary Health and other organizations are experiencing, which is that steady, significant growth in this case, inpatient hospitalizations across our 4 acute care hospitals. As recently as 4 weeks ago, we only had 5 patients that were within our hospitals with COVID. Now we're seeing numbers that are exceeding 30 and growing. And this obviously doesn't even touch the number of patients who are coming to us with severe symptoms that require management but are able to be managed at home. And our ER volume of COVID is also up. Next slide. And then the last thing I just want to show that steady confirmation, if you will, the consistency between all of our organizations in terms of test positivity. We use that magic number of a 5% test positivity rate as being the threshold beyond which an epidemic is considered to be not in control. And our rate has been running consistently in the past few weeks between 13 and 16%. So I share a lot of uncomfortable, more than concerning, in fact, the beginning of alarming numbers. I want to help to this group to send the message that we are not in crisis conditions yet, but we are very close. And our hospital census is very, very high, and that is because of COVID superimposed upon the medical needs of our communities. Those medical needs will not go away. We are at St. Alphonsus within a couple of weeks of having to make decisions about ramping down what we call medically necessary time-sensitive care. That's the urgent needs of our patients. The need to remove a tumor if it's cancerous, the need to intervene operatively to prevent internal bleeding, these sorts of things. And we have not, at this point in time, needed to ramp down that care. But as I said, we are very, very close. We look at that every day. We look at our ICU census, which is full. We look at our inpatient census, which is nearly full. And we realize that the only way that we're going to be able to continue to accommodate this increased COVID volume is to make new spaces available in areas of clinical care that we don't traditionally use. And we started to do that, combined with discontinuing other sorts of care that can be delayed for some period of time so that we can accommodate the more pressing needs. That is the tragedy of the situation that we're in. But again, let me go back to the point that I made at the beginning of my presentation. There are a couple of things that can actually decrease the growth and turn this around very quickly, and they're the things that you've heard about. So if we can encourage one another, our friends, our family, to discontinue close social interaction, don't get together with strangers within your home, maintain physical distance, wear your mask, wash your hands, and find other types of social interaction that is done over the computer, like we're communicating here, or through a window. These sorts of things are the way to turn this around and avoid the impending stress that we are already experiencing.
Thank you, Dr. Nemerson. We have some questions that have already come in. So I'm going to start with some of the ones we got in advance. And I think this one is relevant given what all of you have talked about. Audrey Dutton from the Idaho Statesman asked, how close are local hospitals to being forced to start diverting patients? If and when that happens, where will they be diverted to? Kind of based on what is happening in the Treasure Valley, across the state, and then what we're seeing in other areas around us as well.
Well, Anita, I'll start with that question and then kick it over to some of my colleagues. We are not at the point that we have to divert yet, but within the next couple of weeks, we'll be presumably at or exceeding 100% of census, at which point we'll be compromising other types of care. We would avoid diverting even in that circumstance. And the reality is, where are we going to divert to? We in St. Alphonsus can't divert to St. Luke's if they have no capacity. St. Luke's can't divert to us, and we can't divert out of state because Utah, for instance, is experiencing a surge and is no longer accepting patients. So we have to develop that capacity within Idaho. We already have our surge plans, and we have the ability to accept patients well beyond traditional capacity. So I don't want people to panic. But I want them to understand the reality that we're going to end up having to make very difficult decisions.
I would only, yeah, I echo what Steve said. Where would we divert them to? Utah has made it clear they're not able to accept patients. Eastern Washington is rapidly filling up the hospitals in Western Washington. So yeah, we would lack that. And what we would do is progressively take on more COVID patients, progressively reduce other care. And we think that's all avoidable. We know it's avoidable. We've seen us drop these curves before with good behavior.
Anita, if I could just tag along something, it's a little bit different perspective than the other, than Steve and Jim from the outpatient perspective. I don't know that I can turn on my video. I think you have to do that. Oh, there we go. Yeah, Jim Sousa's laughing because apparently we trade between not understanding how to use Zoom in the other facilities, the other software. What I wanted to say was, which would mirrors exactly what the three others have said. At Primary Health, we are encountering the same issue, which is employees, staff, front office and back office, and of course the providers who are getting coronavirus. In over 50,000 encounters with patients that we've tested for coronavirus, quite frankly, I have yet to be able to find a positive employee that got this from one of the patients. That is exactly what Dr. Sousa said. Here at Primary Health, we distance, we wear masks, we wear face shields, and we wash our hands. On the other hand, on a daily basis now, we have anywhere from 20 to 30 of our employees are out. They either are quarantined or they've had a contact, and of course some have positive results. We have had to close 2 of our urgent care clinics because we don't have enough staff. The point I want to make here is the critical nature of where we're approaching, and we're not there yet. And I might add, we have hired as many new staff as we can. We're running our new employee orientation now daily to try and staff up to meet the demand. But if we cannot meet that demand because we have providers out and staff out, these patients at the very beginning who need testing or evaluation, and of course, many of them don't have COVID symptoms. They have some asthma or strep throat or some other illness. If we can't see them, where do they go? They go to the emergency room. That is the last place in the middle of an epidemic we want these patients. If the hospitals are overwhelmed and we can't see these patients in the front end and they have to go to the emergency rooms, that's very challenging. So I just wanted to make the point that I'm incredibly proud of our staff and what they've done, but they have the same fatigue, working long hours, and we're constantly trying to have people work extra shifts and fill in, similar to what Dr. Nemerson and Dr. Sousa said about their staffs, and certainly not quite as critical as what Dr. Kern has described.
Thank you, Dr. Peterman. We'll get to some questions from media now. Rachel from KMVT has a question for Dr. Kern, or really anyone can answer it. She says, it has to do with hospitalization rate increases. Is there any concern of ventilators running out? Case in point, she read last night that hospitals in Utah are filling up so much that they will have to soon decide who gets treatment. could that happen here, both in the Magic Valley and Idaho as a whole? Anyone can answer.
Yeah, I mean, I think it's possible we could run into the issue with the actual number of ventilators we have. And that was one of the things that was talked about a lot early on in the pandemic, but our treatments have changed a little bit. We were doing early intubation at the beginning of the pandemic. And so I think there was more conversation around how are we going to have enough ventilators to treat everyone. We're not doing early intubation the same way, so I don't think that's where the battle is going to be fought or lost. I think it's really around total staffing and just bodies and beds, the total crush of patients that we'll have, because we're able to maintain a lot of patients off of ventilators that at the beginning we weren't. And then getting to kind of the second question, which is overlapping with this one, which is around, would we need to build, field hospitals or something like that? I would look to the other, Steve and Jim Souza to their answers, but I don't really think that's where the issue is, because who would staff it? We just run into the same problem as what group of trained nursing staff are going to be there to care for those patients. And, if all of the hospitals are full, it means all of the nurses are working to maximum capacity. I don't really understand what that would look like. And I think they've actually been struggling with the same question in Salt Lake City. I know they've talked about building a field hospital, but I don't think it's actually gone up. And the reason they're on divert for ICU is probably more around their inability to upstaff any more ICU volume at that point.
As Jim Souza, I agree with Dr. Kern. We're more likely to run into staff beds as the issue than ventilators. But I heard as part of that question, the sort of crisis standards of care question. Since the beginning of the pandemic, all states have been engaged in getting prepared for the potential to have to implement crisis standards of care, where you make decisions up front about whether someone qualifies for critical care, where you might even be forced to make decisions about deallocation of resources. The state of Idaho is the same as everybody else. The governor impaneled a task force early on. They developed a crisis standards of care framework. Two things need to happen for those to be implemented. First thing is the governor needs to make a declaration that would be statewide, because we wouldn't want to implement that if we had other options, like transferring even to North Idaho, for example, from South Idaho. The second thing that needs to happen is that then the healthcare delivery systems need to stand up and activate the teams that actually do the triaging and would implement those standards. I know that we've been preparing. I know that St. Alphonsus has been preparing. And if a crisis is declared, we'll be prepared to implement those standards. Like nobody wants that to happen. We need to stop that from happening. And we still have this closing small window of opportunity within which we can prevent that from happening with these very simple interventions we've been talking about today.
Yeah, I really don't have much else to add from St. Alphonsus' perspective, except to reinforce what's already been said. I think the one comment I would say personally is, if we have to execute crisis standards, then it's a demonstration of the failure of the community and our leaders to step in and basically turn this situation around.
Joe Parrish from KTVB has a question he can go ahead and answer, or ask his question, and you all can answer.
Thanks, Anita. We've got a lot of questions about what the governor announced yesterday, rolling back to stage 3, and what it effectively accomplishes. I guess for the entire panel, what is your take on the new regulations and rolling back to stage 3? We've got a lot of comments that it appeared to many people that Stage 3 doesn't appear to be much different than what was going on, before the announcement was made yesterday. And then in the context of that, we've also had many questions about people in jest saying, well, is Christmas canceled? But in more serious matters, what can people do heading through the winter months?
I'll jump in first, gentlemen. So Joe, I think it was a step in the right direction. I think two other things. First of all, I heard the governor say pretty clearly that the entities within the state that are actually empowered to act, that have the authority to act, to potentially issue mask mandates or other orders, he's encouraging them to do that. I interpret this as a signal. I think it's at least directionally right. The second thing I'd say is that as healthcare leaders on this call and in other places of the state have increasingly raised the red flag, if you will, of alarm to state leaders about what we're seeing, about how our capacity for care is eroding. I'm pleased that we saw an output from that input, that our state leadership is listening. Now I think we're looking to our local health districts and local leadership to also listen and to act.
I'd add on to that, Jim, to say this is not just about COVID. And I think the part of the message that we're sending today is it's about all other medical care and the fact that we're reaching the limit to provide that. And so if there's some recognition among parents, community members, schools, and organizations that the capacity to provide medical care globally is being reached, then with that reality, perhaps behavior will change. And that's in large part my hope here. We've done well in some ways with people beginning to face cover and to socially distance, but not all. And the expectations that we have of one another perhaps aren't strong enough. And so that's what we really need to leverage at this point in time is one, to have, I want to say this the right way, to have individuals, to have each other, to have the people that we care and love realize that even if you happen to catch COVID and would do well, doesn't mean that something else might not happen to you where you require the services of a hospital or the services of your doctor, and you're going to want them ready and accessible. And that's part of the crisis that's going on here. And hopefully if people recognize that, then they'll start to put that mask on and we'll start to stay apart.
Yeah, this is, oh, I'm sorry, Anita.
Go ahead, David.
Yeah, thank you. Yeah, I just wanted to reference the document that we sent out, which item number 1 is we strongly urge each health district to implement a mandate as relates to masks. Again, I want to reiterate, I believe it's misguided to be arguing about should the governor do this or the governor do that, which then leads to inevitable political second guessing. This group of physicians, in a sense, has a pure goal. All of us have spent our business lives taking care of sick people and keeping people healthy. And we don't know everything, of course we don't, but we know very clearly in this case, with this particular infectious diseases, if you wear a mask and I wear a mask, we can spread this, stop the spread of this virus. And we know if you wear a mask and I wear a mask, we're both protected. And that has to be the most important thing that comes out of this today. And if we follow what the governor says, as Dr. Souza's outlined, that the authority rests with the local agencies, then albeit yes, then the health departments should recommend a mandate. But I would go one step further. That mandate, frankly, is not very effective unless our leaders have the will and we as community members have the will to wear our masks. And I've tried to initiate a rule here at Primary Health for all of our 625 employees, which is what I say at every one of our meetings. If I, David Peterman, do not wear a mask, I expect you to say, David, put your mask on. And it's that kind of responsibility that both Steve, Josh, and Jim have referenced that we need to take.
Thank you, Dr. Peterman. And a follow-up question really that goes nicely is from social media. Has there been concerted efforts by healthcare leaders in the state to contact Idaho lawmakers who still believe this is a hoax and continue to reject proven health policy measures?
We're all involved in any number of engagements with leaders around the state, whether those are in the State Department of Health and Welfare, with the governor's office, at public health districts, and then, because this keeps getting pushed down lower and lower, even at school boards and individual schools. Everybody on this call, I'm aware, because I'm on the same email chains, is up to their ankles in trying to influence the conversation, and I think we can. I have seen that when we get clinical leaders like ourselves in those conversations, maybe particularly when they're more one-on-one, that we seem to be able to move past the throwing of boulders and the politics of this, and we can actually have a conversation about why we need to do what we need to do and how we get there.
Yeah, this is David again. As the chair of this committee, I want to compliment these doctors that are on the call and others that are a member of this group. They're not going to tell you, but they have literally spent hours in the background talking to school boards, health departments, in some respects, political leaders, mayors, and in a non-contentious way. It's to provide the best scientific information. So I just want you to realize all of them, and certainly myself at times, have spent hours trying to give the best information to help, in a sense, get our community to the place where frankly, we can slow this virus down.
Thank you, Dr. Peterman. Joe, you have an additional question. Go ahead.
I'm curious with the trajectory we're on right now, and of course the governor is asking people to wear masks, and it sounds like you're hoping that the health districts will act appropriately in their areas. If things though continue the way they are now, and there are not significant changes at the local health district level, are there projections on where we're headed and what this looks like a month from now, 2 months from now, even I guess weeks from now?
I can start to answer. So St. Alphonsus does modeling, which we update every day. You saw some of it earlier in my presentation, and we're looking at a doubling of inpatient hospitalizations from COVID within the next 2 to 4 weeks. Projecting beyond that, I think, is not really of great value because there's so many variables. But within that next 2 to 4 weeks, then we at St. Alphonsus reach our 100% capacity and begin to to move into other clinical areas that we don't traditionally use. Again, not under crisis conditions. And I would expect sort of similar types of predictive modeling in other organizations, but I'll let them speak for themselves.
Agree with what Dr. Nemerson said. I think what we see, we are projecting the same sorts of spikes in total cases, which will mean needless suffering, needless death, more taxing of our resources, and needless delays in care, all of which can be avoided.
You know, I don't want to distract from the conversation, but I do want to emphasize one really important thing, which is the importance of getting flu shots this year. So I'll just throw that in real quick and we can get back to COVID, to say that flu and COVID together are a deadly combination. So it's really, really, really important this year to get your flu shot and ensure the people around you do the same.
Thank you.
I want to just, oh, I'm sorry, Anita, I keep interrupting you.
Go ahead, Dr. Peterman.
Yeah, that's what my wife says about me for all the years we've been married. And maybe the people I work with. So the point, thank you, Steve, so much. So there is a positive here. I want to let everyone know on this call, and I know Steve and Jim have this also, and Josh. Primary health, one of the great services I think we do to the community is give influenza vaccines. I just looked at the data today. We're up to 27,000 individuals we vaccinated. And so what I'm proud about that, well, of course, primary health doing that, but more importantly is the community is doing that. So there is a positive here. They are getting their influenza vaccine, and I absolutely thank Steve for bringing it up. So I just wanted to give you that positive.
We have an additional social media question. If you were placed as governor or had full control of an entire health district from now until February, what measures would you place on Idaho? What business gatherings take priority? Would you do anything differently than what is being done right now in Idaho?
Not it.
Oh, please, somebody else go first.
Let me, we've already written a letter that suggests that health districts should act in the name of safety and require masks. I think two other things that I would mention if I could be in that scenario. One is I would use us more. I would use healthcare professionals more to interact with state leaders, business leaders, and the public in conveying what we're seeing. You know, not the fake news, not the hoaxy stuff, the actual stories of what we're dealing with inside of our facilities, inside of our clinics, with our people in our communities. I think we are effective messengers, and we should be used more aggressively. Second thing is I think we should be putting our communication effort on steroids. The countervailing opinion that this is either a hoax or it's a nothing burger is, you know, like, they're out there. I know it every day, putting out the fake news, the false information, and we need to counter that. I greatly appreciate an opportunity like this to try to do that, but I think we need to put that messaging on steroids, social media, targeting the young people in particular who, you know, I think if we could change behavior there, we can change the pandemic. Couple of thoughts. Who else wants to be governor for the day?
I certainly don't, but I do want to say that our silence at the beginning of it, answering this question, is because we're not politicians, and we want to be seen as people and physicians who genuinely care and are communicating factual information, not sugarcoating it, and similarly not overly dramatizing it. In terms of what I look to personally, to my political leaders, is courage in taking this true information forward, connecting with other leaders throughout the state to make strong recommendations, and where recommendations aren't strong enough, mandates to drive the public to engage in best practice to protect themselves. The last thing that I would say is that there are now many, many stories of families who have suffered the loss of a loved one from COVID, and patients who have recovered from COVID and are disabled from that disease that are out there. And so I would also be looking to connect with those individuals, because they're the real story of what's going on here. It's not me, it's not my other colleagues, it's the patients who have survived and battled this disease and the trauma that they've had to go through, and the families that have experienced devastating loss as a result of this, and who know what the reality is currently and what it's going to be like as things continue to get worse.
Thank you, Dr. Nimerson. I want to be respectful of everyone's time. We have one more question that came in from Les at the Malheur Enterprise. How often do COVID patients being treated realize that they weren't following mask distancing and then come to a new realization of the need, sort of a change of heart?
I think one of the most compelling stories that I've seen was former Governor Chris Christie's turnaround and expressing significant regret about participating in the Rose Garden ceremony without masks. I think he was, it seems like, quite sick, was in the ICU for a week or so in New Jersey, I believe. But I don't have a lot of personal stories here locally about patients, but it only because of not asking. But Governor Chris Christie's story was very compelling to me.
Thank you, Dr. Kern. And thank you all so much for your questions today and for your time, all of our physician leaders taking time out to do this for us. And we again encourage people to wear a mask when they're out in public. Thank you all.